where we see the usefulness of a multidisciplinary approach, we're talking about non-communicable diseases, and I'm sure that the audience we have today is familiar with the definition of NCDs and the fact that they have a common risk factor pathway. Really, the essence of the presentation today is the fact that we do need to have a multidisciplinary approach. Next slide, please. And the context that I'm taking is one where if we're going to tackle NCDs, so we know that we have this twin or sometimes even quadruple threat in terms of the burden of diseases. One of the major constraints we have is the amount of resources that we can apply to our healthcare. So just put that up just to give a comparison, that in Kenya, we're spending about less than $100 per annum on healthcare in total. And if you compare that with the US, which is something close to $11,500, you can see that we have a huge gap or huge difference in terms of the amount of money that we can spend. Now, when it comes to non-communicable diseases, we know that once they begin, it's a lifetime thing. So, and a lot of it has to do with diagnostic tests and even the treatment and so on. So we do need to think a little differently, because we cannot just import our treatment protocols together with the equipment that is needed and all the tests wholesale. We have to think a little bit about how we're going to manage this, particularly because of the life course that NCDs have. Next slide, please. So typically, when we think about multidisciplinary teams, and I know that we've had these kind of discussions before, we tend to think about it within the context of a hospital, and we tend to think about it limited within healthcare, and we think about the different cadres. So we tend to think a multidisciplinary team consists of basically the clinical care team and maybe just a few auxiliary members. So we think about the doctor, the nurse, maybe the lab technologist. Sometimes we think about it from the perspective of the radiology or the diagnostics vis-a-vis the people who are doing bedside care and so on. So it tends to be, yes, it is multidisciplinary, but within healthcare, and often very narrowly focused within the setting of the organization. And yet, a lot of the frustrations that we have in terms of care are slightly outside of this narrow multidisciplinary team. So many of us will have this frustration of we can't get, the procurement is all messed up and there's a shortage of this or a shortage of that, or there's a delay in getting this particular bit of something, and so on. And so one of the things that I'd like to pose is that we do need to widen a little bit what we term as multidisciplinary. So when we think about the team, can we start to think outside of the confines of the clinical care setting and think a little bit wider about how should we define the multidisciplinary team, and how do we set up means to communicate some of the needs within the clinical care outside to others who would then be part of this team. So typically, when we're thinking about a multidisciplinary team, we'd be thinking about some of the issues. We think about the context within which they're working. So like I said, we tend to think narrowly in terms of geography. So we think that the team should just consist of the people who you see and can sort of, non-COVID, you can sort of touch and feel every day. And a lot of it has to do with the human resource policies around, and also how people get paid. So we have differences between, say, private sector and the public sector, in the sense that private sector, a lot of things are fee for service. So when we're thinking again in terms of the diagnostic side of it, the medical equipment side of it, when it's fee for service, what we do is that you just take the cost of whatever machine you have and you add a margin on top. And then we have issues about how the patient is going to pay. When we think about the organizational context, it tends to be that some of the issues are, one, the goals of the organization. So we're in KNH, for example, and that's public sector. So the goals are a little bit different from a private sector, what can be done and what can't be done. And then there's a big issue, which I think is something that we need to tackle around the information system. So the frustrations we have when something is missing or something is not there, how do we pass that information along? And how can we change that? And then lastly, the team structure, depending on the type of patients that we're seeing. So we're talking about NCDs, and we know that these are people who come repeatedly. They tend to be, for a lot of what the kind of patients that are seen, they tend to be that they are going to be middle age or elderly. So there are issues around that. And then lastly, what I'm going to talk a little bit more about, the roles of the various team members. Next slide, please. So I thought I'd just put that by way of context. So I've talked a little bit about the financing, that we have very little money that we have to manage the issues that we have, particularly non-communicable diseases. And we're trying to have good service delivery. Now, a lot of the costs that we have in healthcare are going to be driven by the kind of medicines and technologies that we have, and the kind of governance structures that are present that either allow or don't allow us to do various things. So because we're going to have this talk about engineering, I thought I'd focus just about the medicines and technologies. And if we have what I would call a lazy approach, where we just import wholesale technologies from outside without evaluating them properly, then we're going to have a really huge problem. We already have, but we'll have a bigger problem in the future. So we need to begin to think about this, particularly in the context of NCDs, the kind of technologies that are appropriate for us and that work in our context, but are also affordable. And then we have to think about the kind of human resource that can operate these technologies. If we're able to save in terms of our medicines and technologies and how we organize our information, then we can make do with the human resource that we have. Next slide, please. So I'm coming to the point where I'd just like to summarize a little bit why a multidisciplinary approach is useful, particularly for NCD care. We know that for a lot of patients with non-communicable diseases, they end up being in a situation where they have comorbidities or multiple morbidities. So we have this big problem of the kind of equipment that they need, medical equipment, and to support the kind of care that they need. If we can develop a system where we have good teams across disciplines, particularly engineering, then we're looking at a situation where we can have standardized equipment. So rather than having even one facility with many different types of equipment doing the same thing, depending on the phase which it was bought and so on, we have greater standardization. And that would, if you look at the lower bit, also look towards improved quality of care. And that would also contribute to equipment that is better suited to the kind of personnel that we have. Now, that requires us to have improved understanding of the clinical and equipment needs. And here there is a challenge. Now, I've just been part of a project for about the last 4 or 5 years where we have been innovating around medical devices. And one of the very interesting outcomes of all this has been that for probably, well, at least the first time we've had this situation where we've brought in engineers into KNH, particularly, and also other health facilities, has been this language barrier between people who are in a very clinical setting and people who are outside. And it is surprising how the languages are very, very different. Yet we can get quite good improvements in terms of clinical outcomes just by getting people with a different perspective to look at the problems within healthcare. So this bit about understanding the clinical and equipment needs and the language that is required, so that translating the clinical frustration into language that an engineer can understand is a critical part of this. And that would help solve some of the issues that we see in the back office before you reach the point of the patient, which is improve logistics, so reduce delivery times. So between the time that something is required and the time that it reaches the bedside would be reduced. And what we're trying to get to is the point where we get lower costs on the back of better product selection. So we don't buy stuff. It reaches our country, we install it, and then discover that it isn't the right equipment. So we need that interface with our engineers. And the last bit is the big one, which is the bit about the maintenance system. If we have these interactions and we have this multidisciplinary approach, then we're able to improve our ability to plan for better outcomes in terms of the equipment that we need. And this would be on the back of improved skills for maintenance and also calibration. Part of the project that I just mentioned, the Maker project, we did install the first calibration unit in KNH, which is now functional. And this was actually a surprise because prior to this, we'd have equipment that would go for many years without any sort of calibration. So you really don't know whether the machines that you're using, from just the basic BP machines all the way through, have been properly calibrated over time. Next slide. So in conclusion, we do need to have a multidisciplinary team approach, and we need to have it a little wider than the traditional way that we think of just the different cadres within healthcare. And the idea is that it's not sustainable to have a vendor-led approach where we import and then have to adapt to expensive machines that come from outside of the country. So we need to begin to think for NCD, how can we have our own machines that have been adapted to our own situation? So I think that's the last slide. Thank you. So